what I'm going to do today, so I work at Texas Children's. I specialize in Chiari, and I wanted to talk about what I think you should know about Chiari. And so, let's see. So we'll go through a few learning objectives, background and causation of Chiari I malformation. You know, why do we have it? Basic anatomy and physiology about Chiari. What is complex Chiari? Have you all heard about complex Chiari? So it's a new term a colleague of mine came up with that talks about Chiari with extra things. And so, and then what's the usual treatment for Chiari in complex Chiari? We'll talk a little bit about the guidelines that I helped to create, and then Chiari databases that we're putting together, and then we'll talk about where do we go from here. So this guy is Dr. Hans Chiari. So this is who Chiari is named after. He was a pathologist working in Vienna and Prague, and not a surgeon. He didn't treat any patients with Chiari, but he described Chiari, and this is through some autopsy cases, and so patients who died with Chiari. And there's another doctor, Dr. Julius Arnold, who helped to describe a similar patient. So sometimes you'll hear Arnold Chiari, but usually when I'm talking with colleagues, we'll just talk about Chiari malformation. This is so I always like to think what's no Chiari. So if you don't have Chiari, what do things usually look like? And you can see over on the left, this is a picture of a child. Here's the cerebellum, so this is the back part of the brain, and you don't see any of the cerebellum coming down below the bottom of the skull. So this patient has no Chiari. This is sort of what a brain usually looks like, and the picture on the right is the same brain. It's sort of a slice through the center, and these are the ventricles, the fluid-filled cavities, and the patient doesn't have hydrocephalus, and so that's someone without Chiari. This is someone with Chiari, and so the things that you can see over here, the cerebellar tonsils, you can see how they're coming down below a line that's here at the bottom of the skull, and so that's the definition of Chiari, and this is really based on radiologists. So a radiologist said, well, how can we define Chiari? And it's usually about 4 to 5 millimeters of, we call it tonsillar descent, or sort of the cerebellar tonsil coming down below the bottom of the skull that institutes Chiari. And so otherwise, there's a normal connection here between the skull and the spine, and complex Chiari, that's the part that's not normal, and the part that can cause symptoms. And so looking at Chiari II, have you all heard of different variations of Chiari? And so these are based on the anatomy work by Dr. Chiari back in the 1800s. And so Chiari II is actually a condition where the vermis, and so it's a different part of the cerebellum. It's sort of the center part of the cerebellum comes down. You only see it in patients with spina bifida or myelomeningocele. And so most people don't have Chiari II when you talk with patients, other people that have Chiari. The Syringomyelia, so that we're all on the same page, you can see two pictures here. Both patients have Chiari, and so that's the cerebellum coming down, and then you can see a syrinx, which is a fluid-filled cavity that's in the spinal cord. So you shouldn't have fluid in the spinal cord. The spinal cord, when you start out as an embryo, it's flat and it rolls into a tube. And so there's always a potential space in the center of the spinal cord for fluid. And so if there's some sort of disruption in the flow of spinal fluid, or if you have a tumor in the spinal cord or some sort of blockage, then fluid can go into the spinal cord and form a sort of a cavity, and that's what a syrinx is. And so you can see the syrinx here, and then in this patient you can see the syrinx as well. And so, so what causes Chiari malformation? We think that there are actually multiple causes for the problem of having the cerebellum coming down below the bottom of the skull. And so one thought is you could have a small posterior fossa. So the posterior fossa is this part of the skull. So if you can imagine, if this part maybe didn't form to be the size that it's meant to be, that as the brain grows, then it could grow down. And we find that actually in a breed of dog. It's called a Cavalier King Charles Spaniel. And so this breed of dog was bred to have a small back of the head because aesthetically that's what the breeder wanted. But then they found that every dog has Chiari, and many have Syrinx. And so there's actually a vet surgeon that learned from a pediatric neurosurgeon how to do a Chiari surgery in a dog. And I think they're in New Jersey or New York. And so the other cause of Chiari, you can imagine if you have a tumor or hydrocephalus, that means fluid in the brain, and if it's pushing down, it could push the brain down and then cause the same thing, part of the brain coming below the bottom of the skull, Chiari. And so as a neurosurgeon, we always look at the brain to make sure there's not something we can treat. And I have seen a few patients come in with brain tumors that thought they had Chiari, they actually had a brain tumor. The Chiari II malformation is from a problem in utero. So before you're born, where spinal fluid's leaking out of the back of patients because their spinal cord is on the skin, and so that sort of draws the brain down, and that causes the Chiari in that situation. So what imaging is needed if I have Chiari? So patients will come to me with Chiari. They might have sometimes headaches and symptoms and weakness, and that's why a doctor got an MRI. I have other patients who might have had a sports concussion, and so, or a car accident, and then they have a scan of their head and they find Chiari, and they otherwise have no symptoms, and that happens from time to time. And so typically with Chiari you have other associated findings, and so you want to look at the brain but also the spine to make sure you know everything about what's going on so you can treat it in the right way. And so we'll get a brain MRI, we'll do an MRI of the spine typically, possibly a CT of the neck if some of the bones are sort of congenitally fused together, which can happen sometimes in complex Chiari. Sometimes we'll get something called dynamic imaging, where you'll have your head in flexion and extension, and we'll get pictures in both positions to see if there are changes in the skull base. And all of these things are needed to understand everything about the condition so that we can treat it in the right way. And so not everyone with Chiari needs surgery, and patients who do need surgery, not everyone necessarily needs the same surgery. So who might benefit from surgery for Chiari? So patients with symptoms might benefit. So the question is, what are the symptoms? And so patients without symptoms do not need surgery, and this is well studied. There are sort of case series where we'll see every patient with Chiari, and we'll kind of see how these patients do. And I have many patients who have never needed surgery that I've followed in clinic. And so that's something that is very important to know, that just because you have it doesn't mean that you need surgery. You need surgery only if you have symptoms. And so determining the symptoms are challenging at times because you can have headaches for different reasons, right? And so are my headaches from Chiari? I've had patients who have had migraine headaches and Chiari that was incidentally found. And I said, look, you don't need surgery. You should go to a headache neurologist and be treated for migraines, and the headaches are gone with medication. And so Chiari headaches typically don't go away with medication. And it's because of the structural sort of changes and the blockage of the flow of spinal fluid and compression of the brainstem. And I'll go into that in a second. And so it's very important when I talk to patients. I have also some patients who have Chiari headaches, but also migraine headaches. And I'm very upfront saying, look, I think some of these headaches will get better with surgery, but other headaches may not because they're not related to Chiari. And so, and it's also very important. There's no need to do prophylactic surgery. So to do surgery now to prevent bad things from happening in the future. We only do surgery if there are headaches. And so we know this. There are a couple of natural history studies of patients with Chiari. One, I used to work at Dartmouth, and so I was part of that study. We had 52 patients that were followed with yearly MRIs for 8 years, and very few of these, these are patients without symptoms, and very few had any changes on the MRI from year to year, and very few patients ever developed headaches and needed surgery. There's a larger study at Children's Hospital of Alabama that found something similar with shorter follow-up. Is it safe to play sports with Chiari? I get this question quite often. We do have some data on that. There are 21 case reports of patients with Chiari deteriorating following a trauma, with 4 cases of actually sudden death. But there's a study of over 700 pediatric patients who played sports and all had Chiari, and there's no increase in injury or concussion in patients who don't have symptoms. And we know that the incidence of Chiari malformation is actually quite high. So we think maybe 1 in 300 people to 1 in 500 people might have Chiari. And so if you can imagine that many people have Chiari and that many people don't have symptoms, it's probably safe to play sports. If you have Chiari and you don't have symptoms. I was at a national meeting, and we asked the pediatric neurosurgeons whether they would let their patients play contact sports after they had surgery, and half the surgeons said yes and half said no. I personally let my patients play contact sports if they'd like to. I talk to them about risks and benefits. I've never had a patient have a problem. And so I think it's probably safe as long as you're symptom-free. There's a few studies about Chiari with a large group of patients. This is one from Dr. Oakes with 500 patients. And the way I look at these studies, so this is so surgeons will often do this. You'll look at how patients have done over time, and you'll talk about the symptoms that got better and the complications of surgery. And I think as a patient, I would like to know that, because I would want to know what symptoms might get better and sort of what are the risks, right? You know, if I undergo a surgery, that's very important to know. And so in this study, 40% of the patients presented with headaches, 18% had scoliosis. The average hospital stay was around 3 days, about 12 days before patients got back to school. The rate of complications was about 2%. 4 patients needed a fusion of the spine, and so you may read that some patients with Chiari might need to have a fusion of the spine between the skull and the upper cervical spine. That is not common. I do that surgery, and there are definitely patients that need it, but most patients with Chiari don't need that. 4 patients had something called a shunt, which is a tube from the brain to the belly to drain spinal fluid. There are similar outcomes with a large database study called Park-Reeves. I was part of this study. This is a multi-hospital collaborative, so 692 patients. It's a lot of patients to study. And the PFD is a decompression. The PFDD is decompression with duroplasty. So that's where you sew in a patch into the covering around the brain to give more room, because Chiari is a problem where there's not enough room around the back of the brain, and so that causes the obstruction of spinal fluid and some of the symptoms. So in this study, there were a few patients you can see who had a spinal fluid leak. So that's fluid leaking out through where the surgery was performed. A couple patients had meningitis or hydrocephalus. 4 patients had instability and needed fusion, but this is out of, again, almost 700 patients. And so those are rare problems overall for patients that have Chiari malformation and need surgery. And so how is surgery performed? So this is a sort of a schematic. You can see it's an incision that's in the back of the head. It's in between muscles that are between the skull and the spine, and we'll go in. We'll remove part of the bone. We'll remove part of the lamina of the first cervical vertebrae, called a C1 laminectomy. So that's the first vertebrae in the spine, and the lamina is just the roof of the canal. We'll look into the fourth ventricle, which is the fluid-filled cavity in the bottom of the brain, to make sure that it's open. Sometimes surgeons will do something called tonsillopexy, or a tonsil resection. So this is where you cauterize or remove part of the brain that's coming down below the bottom of the skull. And then we'll close everything back up with stitches. And so this is just a picture here of the bone removed, and this is the dura, the covering around the brain. And here's a picture. You can see the cerebellar tonsil coming there, and we're going to sew in a patch for extra room around the tonsil. And so what is complex Chiari, and is it important? So that's Chiari plus additional anatomic problems. And so the skull could be settling on the spine could have abnormal joints or fused joints. The skull could be poorly attached to the spine, so unstable. Or the spine could be pushing into the spinal cord brainstem, causing symptoms. And so I'll talk. There are a few measurements. You might have heard of a PBC2. This is a measurement that most Chiari surgeons will do to look at the amount of compression of the front of the spinal cord from the second vertebrae kind of pushing back on it. There's something called a CXA, or clival-axial angle. So this is basically an angle between the skull and the spine, and you can see in this picture, if it's more acute, then you can have kinking of the spinal cord, and that can cause some of the symptoms of brainstem compression. There's another measurement that looks at sort of the alignment of the spine, and then there's a term called basilar invagination. You might have heard this, but this is basically just a condition where part of the spine, you can see over here in B, part of the spine is actually coming up into the skull, and you can imagine that it's causing compression often of the brainstem. And so there are a few patients with Chiari that need additional surgery with a fusion of the skull to the spine, but also we'll sometimes go through the mouth or through the nose, and we'll remove some of the bone here that's basically compressing the brain. And so that type of surgery is pretty rare, I'll have to say, but experienced Chiari surgeons will likely have an experience with this. But this is something I always look at for my patients, but it's rare that I'll need to do this type of surgery. So is every Chiari malformation the same? This is where I'd like you all to understand how variable Chiari is. Again, it's not the same for every patient. That's why some people have horrible symptoms, some people have no symptoms, and why the symptoms that people have with Chiari can be varied. Most people with Chiari can have headaches in the back of their head with coughing, sneezing at sports, but not everyone. Some people can have other types of headaches. Some people can have swallowing problems. Some people can have eye movement problems where the eyes don't line up. Some people can have sleep apnea, and something called central sleep apnea, where your body just doesn't breathe at night when you're asleep, which can be scary. And but symptoms that go away with surgery, and it all depends on what part of the brainstem is being compressed, and if the flow of spinal fluid is being blocked, and in what way. And so this is a patient, this is sort of a typical, when you think about a typical patient with Chiari, and I talked to another neurosurgeon, this is what that neurosurgeon would imagine. And so it's part of the cerebellum that's coming down. But this patient also has Chiari. And you can see that there's really a whole lot more cerebellum coming down, and you can see the kinking here and the compression in the front of the brainstem. This is a other patient with Chiari, and you can see some of the brainstem or the cerebellar tonsils coming down, but you can see the fluid in the brain. And so this is from hydrocephalus. And then here's a patient with a fusion of the spine and Chiari. You can see over here how these two bones are fused together, and then you can see the Chiari malformation, and that's would be called a complex Chiari. And here's another patient with Chiari, and look at how different this is. You can imagine, you can kind of see how the front of the brain is being compressed, and how everything looks like it's just being pulled down. And so again, all patients are called, you would be told you have Chiari, but again, you can see how very different it is from person to person. And so there are other diagnoses that may go along with Chiari. I don't have enough time today to go into great detail, but there's hypermobile Ehlers-Danlos syndrome, where sometimes you can have loose connections between joints and have symptoms from that. Something called a Klippel-Feil syndrome, where you can have fusion of some of the vertebrae. Basilar invagination, that's where the skull sinks down in the spine. Tethered spinal cord, that's a condition where the spinal cord is lower in the spinal canal than it should be, and that can possibly be related or pulling things down. And then there's something called dysautonomia or POTS, and so these are conditions that some people with Chiari have. It may not be related to Chiari, but may be an associated problem with Chiari, and may need special treatment. And so Chiari, what's the data? So as a surgeon and as a scientist, I like to be data driven. So I want to study things. I want to know what the real answer is. And so I'm part of multiple collaboratives or consortiums. These are groups of surgeons that pool our sort of outcomes to see if we can find sort of the best answer, the real answer for a problem. And one of them is Park-Reeves. Another is the Chicago Chiari Outcome Scale. So this is a scale, and so if we're talking to other surgeons, how do we know that my patients are doing as well as another surgeon's patients? And so you need to have sort of a common language, and so that's a common language we can use to evaluate for success. There's the Congress of Neurological Surgeons guidelines on Chiari. So again, I help to produce these. They're free, they're online, and they're not light reading, but I think you could learn a lot from them. And they can point you in the right direction to actual articles, like research articles if you're interested. And then we also have a Bobby Jones Chiari and Syringomyelia Foundation patient database. The Chiari guidelines, just in brief, I'll let you look them up on your own time, but we looked at, we have 3 chapters. We looked at the diagnosis of Chiari malformation, the treatment of Chiari malformation, and then we looked at some additional questions. And so, for the diagnosis, it was basically what studies do you need to adequately sort of understand a specific patient's diagnosis of Chiari. For the treatment, we looked at whether prophylactic surgery is needed. Should you have any activity restrictions? Should your family get screened? Is there a genetic basis? We're actually learning more about that. There are some families where multiple family members have Chiari, and so there could be some genetic tests. And currently we're doing genome sequencing through one of our colleagues at Mass General Hospital. And so that's, if you're interested, you can do a little cheek swab and submit data for that. And then for our third question, we looked to see whether you need to do duroplasty, which is the patch. whether you should cauterize a cerebellar tonsil or fuse the spine in some patients. So these are what kind of long-term follow-up is needed. So if you have surgery, you say, oh, I'm good. Or if you have surgery, do you need MRIs along the way? Do you need a surgeon to follow as you grow up? And so we tried to address those questions. And so, so I have just in closing, just a couple pictures. I again am a visual person. I think it's important to kind of see things. So this is a patient with Chiari and a syrinx before surgery, and so after surgery. So the goal that I have is to remove bone, and you can see the skull bone called suboccipital decompression, and then the C1 laminectomy, and then I sew a patch in, and you can see all the space that wasn't there before. So that's what I look at as a successful Chiari surgery from an MRI standpoint. You can also see the syrinx, the fluid collection is gone, and most importantly, the symptoms are better. Obviously, that's the goal of the surgery, but these are ways to look at success on an MRI. Here's another patient. This is abnormal eye movements, abnormal reflexes, weakness, urinary incontinence, and you can see after surgical decompression there's additional room, and with some resection of a tonsil and with some duroplasty, symptoms resolved. So I hope that I've been able to go through sort of the background with Chiari malformation, the causation, the basic anatomy, the physiology, what's complex Chiari, the usual treatments for Chiari and complex Chiari, and then also talk about the guidelines and the Chiari databases. And so where do we go from here? I've got a wonderful team. They allow me to specifically take care of patients with Chiari while they take care of patients with other neurosurgical problems. And so I really think it's the research, and I think we're getting there. I expect the next 10 years to give us a lot of answers. I think the genetics behind it. So if Chiari really is multiple different problems that are all causing the same problem on the MRI, and let's say all of these things need slightly different treatments, it's possible we could have a genetic test that could say, hey, you need this treatment, you need that treatment. Gosh, I think you're never going to need surgery. I am very hopeful. But until then, I think it's important to learn about Chiari, learn everything you can about it, ask questions, and I do think supporting each other, I do think that that can go a long way. So I appreciate you all listening to me and for your attention, and coming here today. I appreciate Bobby Jones being here to helping me put this together, and Texas Children's and all of my support.